Hello, everybody, and welcome to this session one of day two. My name is Sahil Parikh from Columbia University in New York, and I'm delighted to welcome you to the session entitled Pulmonary Embolism Guidelines, Evidence, and Interventional Decision Making. In this first session of day two, we'll focus on PE, the evidence, the guidelines, and the decisions that define how we manage this condition today. Joining me for this session are four outstanding colleagues whose work in the space speaks for itself. We have Sanjam Sethi from Columbia University, my partner in New York, Dr. Jay Matthews from Manatee Memorial Hospital in Bradenton, Florida, Dr. Greg Piazza from the Brigham and Women's Hospital in Boston, and Dr. Jay Geary from the Hospital of the University of Pennsylvania in Philadelphia. So let's get straight into it. Sanjam will open us up with a comprehensive review of the PE data, landscape, and the technologies shaping our approach. Sanjam, the stage is yours.
Great. Thank you so much. Excited to be here and happy for everybody to be zooming in. I'm happy to sort of set the stage, and then I think my colleagues are going to go more in depth, especially into catheter-based technology, and really talk about why we're using catheter technology in the PE space and what the data behind that is. These are my disclosures. And so as you're all aware, pulmonary embolism really exists on a spectrum, and it's a spectrum such that the RV accommodates as there is pressure on the RV from the obstruction of the pulmonary artery circuit until it sort of fails rather suddenly, and then the patient goes into a shock state, which can often be very quick and very deadly. And of course, we want to rescue those people who are already in shock, and there is potentially a role for catheter therapy in that population, as we'll talk about. But the truth is that the vast majority of catheter interventions are really being done on this group that is just sort of peri-shock or towards the end. And how can we ascertain those patients who are really the most at risk for decompensating? And can catheter therapy prevent that decompensation? That's what we're really trying to understand. When you sort of think about how to risk stratify patients, so we understand who is in those higher risk cohorts. This is from the old, now old ESC guidelines from about 5 years ago, which really the focus is as the patient gets progressively more sick or has worsening clinical parameters, you can see that there's RV dysfunction, and you can see that biomarkers elevate. And if they're hemodynamic unstable, those are the highest risk patients, which were termed high risk. And the ones right below that, which have evidence of RV strain on imaging, as well as elevated clinical parameters and troponin levels, were in that intermediate high risk group. And these are also probably the patients that really benefit best from catheter therapy. And I know Dr. Greg is going to really go into how this translates into some of the new guidelines, but this is the framework under which we're working. No matter which set of guidelines you're looking at, the framework is really the same. There is a gradual increase in the level of risk, in which case therapy, whether it be catheter or surgical, becomes more and more appropriate. This is a very similar schema, which sort of lays out some of the different therapy options, especially in those risk groups. And when you sort of look at it in terms of the new guidelines, we're really talking about those patients who are in E, which would be previously high risk, and then C2 to D3 to C3 to D2, which is previously intermediate high risk. And the reason this all matters is that pre-2010, if the patient had hypotension, we gave them this drug, which is alteplase. If they had any other P, we gave them unfractionated heparin, maybe low molecular heparin, then we sort of cross our fingers and wash. And the truth is that today we have all of these different options in PE that we can employ. On the left are technologies that are particularly geared towards clot removal or clot dispersion and are really treating the source. And on the right are adjunctive therapies that may help support in terms of PE management. So when we look at like how catheter therapy evolved, we can look back at the PITO study, which from 2014, which suggested that full dose anticoagulation, full dose thrombolysis versus anticoagulation alone in patients who are not hemodynamically unstable, so that intermediate high risk group or that C3 to D2 group, showed that there was less PE related death, less decompensation, but unfortunately the bleeding risks were untenable. So when you did a meta-analysis of all the studies, including PITHO, it looked like there may have even been a mortality benefit, but there's a threefold increase in major bleeding. So the thought was, um, what can we do to lower that bleeding risk, but still achieve the same beneficial effects in this intermediate to high risk population? Catheter thrombolysis was one of the first technologies after that to be FDA approved. It suggested that if you take a catheter and put it directly into the clot and drip the TPA slowly directly into the clot, you can decrease the dose and thereby decrease the bleeding hazard. The main technology that was first FDA approved was called ECOS, that used ultrasound in addition to the thrombolysis. There was a small randomized control trial which suggested that there was a benefit to the surrogate endpoint of RV-LV ratio versus heparin alone at 24 hours. And then that was maintained in multiple single-arm registries, which suggested that PA pressures were reduced, as well as RV-LV ratio was quickly resolved. The next technology, which shortly thereafter was approved, was mechanical thrombectomy. There are many devices now on the market, but the fundamental premise is the same. You take a catheter that is somewhere between 16 French and 24 French, place it into the pulmonary arteries and aspirate. And no thrombolysis is required, although some adjunctive thrombolysis has been used in rare cases. Now, most systems have some sort of adjunctive mechanical component to pair with the aspiration, but quite frankly, those are less effective than the pure aspiration in the vast majority of patients. And similarly, when we look at the large registries, this is from the Inari device, the FlowTriever study. This is, I think, 800 patients in the Flash registry, which suggested very high rates of improvement in RV-LV ratio and very low complication rates. Similarly, when we look at data from the Penumbra catheter, which is a medium bore catheter, similarly low rates of complication and or bleeding in large registry sets. So this has spawned this entire field, and you can see here, this is the current US FDA-approved catheter strategies for thrombus removal. There are multiple large bore thrombectomy devices on the market, one predominant small to medium bore thrombectomy device on the market, and then multiple catheter thrombolysis on the market. The primary being ECOS that is used, and then the Bashir endovascular catheter is sort of a hybrid with some mechanical component in addition to thrombolysis component. And so when we think about what is the role of these technologies in different disease states, so we're just going to take, again, based on the old criteria, high risk, which is now determined E, AZC AHA-E, and then intermediate high risk, which is ACC AHA C3 to about D2. And when you look at the high risk group, this was studied in the FRAME trial. This was a single arm parallel registry looking at standard of care versus the FlowTriever arm, and it suggested that although these patient subsets this is not randomized, so they were different, the FlowTriever arm had a lower rate of the composite primary endpoint versus the context arm, suggesting that at least in select patients, catheter thrombectomy may be very appropriate in this highest risk cohort. So these are patients that are hemodynamically unstable. This is now being tested in a randomized trial fashion in the Persevere study. This is off and running, 200 patients to recruit. It is a difficult study to recruit because these are those highest risk patients that need really very quick evaluation and treatment. And your 200 patients are being randomized one-to-one to either FlowTriever or standard of care. So hopefully we will have an answer to that question in a randomized fashion relatively soon. When we look at the intermediate high-risk cohorts, and that's that cohort just below, again, this is those C3, D2 patients. Published trials have suggested that RVL ratio across multiple different single-arm studies, even some randomized studies, suggested that that is reduced quickly and appropriately. There's good thrombus reduction. There's low adverse events. But what is the randomized data behind this? And I think we're entering that sort of golden age where we are really looking at this in a randomized fashion, whereas fibrinolysis, catheter-directed was a systemic, and then catheter-directed was first studied, then catheter thrombectomy. Now we're really moving into RCTs to compare these technologies, not only amongst each other, but particularly against standard of care, which is anticoagulation alone. And those are really what we want to understand. Is there a mortality difference? Is there a difference in clinical decompensation? Is that short-term or long-term? And then what are the effects on the long-term endpoints, such as post-PE syndrome and CTEPH? So this is a group of studies that has reported or will be reporting. We're going to talk about HiPytho, PE Tract, and Peerless 2 here. But everything that's dotted is a randomized control trial. So HiPytho was just released at the ACC this year. This was looking at a enriched intermediate high risk population, looking at a 7-day composite endpoint of PE related mortality, cardiorespiratory decompensation, as well as PE recurrence. 544 patients were randomized, and we were really looking at patients that had a elevated troponin RV-LV ratio that was enlarged, as well as at least 2 onset clinical criteria, suggesting they were really in a higher risk cohort. And we have Greg Piazza on the call, who was one of the PIs of the study, who could certainly lend more color here. And when we look at the primary efficacy outcome, there was a significant decrease in cardiorespiratory decompensation or collapse in the ECOS group, which had a relative risk of 0.39, which is quite striking. There was no difference in PE-related mortality and PE recurrence, although I will say that those mortalities may have been stemmed because crossover was allowed if the patient wasn't doing well. That's why I think decompensation is going to be the primary thing that drove the primary endpoint in this particular study. These are the major PE RCTs, as we just talked about HiPytho. The similar analog for catheter thrombectomy is Peerless 2. That is still enrolling, although Dr. Geary is a PI and can tell us where that is. It apparently should be finishing up very soon if it hasn't already. PE Tract, I will highlight for a second, which is a study looking at any FDA technology, and that outcome is a 3-month endpoint of peak VO2 measured at CPAT. So really trying to get at some of that functional outcome after the acute phase, and that is very, very close to finishing at this stage. Peerless 2, like we mentioned just now, is 1,200 patients. Again, looking at RV dysfunction plus risk factors, and it's looking at a win ratio, looking at all-cause mortality, clinical deterioration, readmission, bailout, and dyspnea at 48 hours. Pytho 3 is going to look at systemic fibrinolysis, looking at a lower dose. So it's really recapitulating some of the from the original Pytho and looking at a much lower dose and trying to pick again that enriched population and see if that systemic fibrinolysis can measure up versus some of these catheter technologies. That's revisiting the systemic fibrinolysis hypothesis. Peerless, a quick mention of Peerless. So Peerless was a randomized trial that has finished that looked at catheter thrombectomy versus catheter thrombolysis, looking at all-cause mortality, intracranial hemorrhage, major bleeding, clinical deterioration, and intensive care unit / length of stay. And it did suggest that there was a benefit to thrombectomy in terms of deterioration, bailout, and ICU admission, but the hard endpoints of all-cause mortality and bleeding were not different between the two groups. So where does that leave us? Again, Greg will go through the guidelines here, but right now in those highest risk groups, catheter technology in category E is a 2A. Everything is a 2A in that group, whether that be systemic fibrinolysis or catheter technology. And then for category D, catheter technology is right now a 2B, which means that this data is really going to be fundamental in how we think about this. So in summary, PE therapy has evolved dramatically in the last 15 years. All catheter options at this point are considered reasonably safe. We should be considering catheter therapy for C2 patients and higher. You could argue C3 patients and higher. The population that best benefits from catheter therapy is likely the highest risk patients, and that will be clarified, already has started to be clarified in randomized control trials. And then, really be facile across the entire toolbox and landscape so you can deliver the best therapy for your patient. Really, thank you for your time.
Sanjam, that's an incredible overview of a very, very complicated topic. We have a lot of questions showing up in the chat. I just want to start with the basic question for you. What's the biggest value proposition of treating these patients invasively? Is it acute management or is it a long-term management?
Yeah, right now, certainly, I think acute management has been defined much more clearly, right? For those patients who are category E, high risk, you really want to rescue them away from their shock state. For those who are sort of bordering towards shock, we do see that if the natural history of these, a large a certain percentage of those patients will decompensate, and you really want to sort of get them off that ledge. Long term, we don't know yet. Pediatrics is going to give us some information. And certainly, we are really gathering data on does acutely treating this patient lead to any functional benefit in terms of CTEPH and CTED down the road. So, really undefined at this point.
And I'm going to ask in rapid fire, all of you, what's the one parameter that makes you worry about a patient that comes in with an acute pulmonary embolism?
Yeah, I really agree with Jay. It's Jay Geary. It's the lactate. I think that's the thing that distinguishes patients, who don't have an obvious hemodynamic issue on blood pressure as high risk.
Right. So it's no longer just the vital signs. It goes beyond that. I think that was the point, is that biomarkers are incredibly important. And I think that that's where the sophisticated teams that have had lots of experience are moving in the field. So we're going to get to a lot of the guideline discussions as we get further into the session. Let me move ahead to Jay Matthews, who's going to walk us through a recorded case demonstration of large bore thrombectomy in acute PE. Jay, over to you.
All right, great. Thanks for having me. I get to present a large bore mechanical thrombectomy using the penumbra system, which is really more actually medium bore thrombectomy. So these are my disclosures. I do work with a number of thrombectomy companies. So I'd like to put thrombectomy in context. We have small bore thrombectomy, which is typically the 6 to 8 French realm. It's smaller profile, it's safe, but then the cons are time and efficiency. There's medium bore thrombectomy, which really I consider between 12 and 16 French. So lower profile, it's safe, but of course with large central organized clot, sometimes that can be a little bit more challenging with these devices, but it can be mitigated with some newer techniques. And then, of course, there's large bore mechanical thrombectomy, which is 20 to 24 French plus. It's very efficient. Of course, there can be sometimes risk with large bore devices and also difficulty with distal clot. So my algorithm, this is beyond the guidelines as well, too, because the guidelines were reflective of the trial data that was available at the time of publication. But really with minor P, the A to C1 group, typically we treat with medical therapy. In the submassive P population, the C1 group really is a data-free zone, and medical therapy is probably appropriate, but there are some patients that we do occasionally offer some type of therapy to. But the C2, C3 group, which is currently in the guidelines, still unknown, waiting the trial data. And we talked about Storm P and also High Python coming out, which support use of mechanical thrombectomy or the catheter-directed thrombolysis for submassive P. And in my algorithm, I do utilize these technologies and further stratify them based on their PA pressure, because we know that high PA pressures are associated with more challenges, especially large bore thrombectomy. So in patients with high PA pressure, I tend to use more catheter-directed thrombolysis or the flash system. Patients with lower PA pressures, it's kind of dealer's choice and can be defined further based on their clot location. And then, of course, massive PE patients, we've already discussed this as well, too. The ones that are too unstable to go to the lab will get lysis, but those that are stable for the cath lab can be potentially mitigated with ECMO and then put back into this algorithm. So this is the Lightning Flash 3.0 system. With every iteration of the algorithm, they've had significant improvements in blood loss mitigation. So essentially a 50 to 60% reduction in blood loss to finally to this third iteration. It's a 16 French system, laser cut hypotube that's highly flexible, and then they essentially moved the pump, the sensing technology rather closer to the catheter to reduce the distance and also improve the efficiency to be able to detect whether or not you're an open vessel or on thrombus. And this gives you both audio and visual cues to allow for faster clot removal and ultimately a more efficient type procedure. So this is a clinical case. A 75-year-old gentleman with likely provoked VTE presented with severe hypoxemia, tachycardia, and hypotension. He was morbidly obese. His heart rate was 130. His blood pressure was low. His systolic blood pressure was 80, and he was on vasopressors, both norepi and epinephrine. O2 saturation was 89% on 100% downward breather, which is a very poor prognostic sign. His initial PA pressure was very high in the 70s, so you know that these patients typically, even in massive PE, present with high PA pressure. Usually this is indicative of underlying pulmonary hypertension at baseline. His initial cardiac index was low and his lactate was high. And as we mentioned before, to a lactate above 4 is a very poor prognostic sign. So I always do an initial venogram in both access sites to make sure that there's no iliofemoral iliocable thrombus. That will impact us as well too. And so you can see this is the CT scan that shows a large saddle pulmonary embolism with a very large right ventricle. RV to LV ratio is essentially 2 to 1. And so you can see this is that initial venogram. I use the left groin for my imaging catheter, which is typically an angled pigtail catheter. And then on the right side, that's where I'm going to take my 16 French device. Essentially, you can see how much of the catheter is bent here because that right ventricle is so huge. And you can see this is where I'm taking a medium supportive wire. So I'm using a glide wire advantage to traverse through the right heart and essentially deliver my flash catheter. So what I find here as an advantage is that I'm able to avoid using the Onplat super stiff wire, which is quite stiff and can sometimes impact the RV function as well too. Patients will sometimes decompensate when you take very large bore catheters and large stiff wires to the right heart when it's very sick. So you can see here, look at that bend. In order to even get to the right side, I had to go to the left side first. And this is the flash catheter. The element sheath is hanging back down at the RA cable junction. And then I'm bringing my catheter up, and it's got a little dilator called a Select Plus, which is very soft, allowing me to advance the catheter atraumatically. I pull my wire back and essentially flip over to the other side. This is using a mother-daughter technique, and I'm able to advance my sheath all the way up then into the main PA. After this, I pull my wire out, and I'm able to advance the catheter because the tip is very atraumatic to be able to remove thrombus. Again, rotating the catheter back and forth, making sure that I'm not really shoving up against the wall. And then you can see here we have some improvement. There's still quite a bit of thrombus there as well too. And so again, continuing the same type of maneuver, going down further, going to the right middle lobe of our pulmonary artery, and then also going into the truncus arteriosus as well too. And you can see that's what we're essentially doing here. And you can see overall the perfusion has improved significantly. There's still some residual small thrombus here, but again, going after that likely doesn't improve the patient's outcomes. We're just trying to improve the overall perfusion. We notice that the distal arborization has improved. And so I go ahead and now flip over with this catheter just simply over to the left side. Again, no wire needed. I'm just able to flip my catheter over, and then we can take a picture here showing that there's significant thrombus burden here in that interlobar branch of the lower lobar pulmonary arteries. And again, same technique, rotating my catheter around, advancing it forward, and I'm able to then remove the thrombus here fairly readily with improved perfusion overall. You can agree that the distal arborization is significantly improved, and overall, I think this patient's clot burden is significantly reduced. So the patient had on-table symptom improvement. This is one of the things I definitely look for to see how do their hemodynamics respond, does their oxygenation improve. So it was nice to see the heart rate came down, the blood pressure improved. We were able to wean him off of vasopressors on the table. And his O2 saturation improved dramatically. We were able to de-escalate him from 100% non-rebreather. And at the end of the case, when we got him off the table, onto the stretcher, he was on room air. And then the PA pressure also improved down to about 51, which is likely the patient's baseline. Again, looking to see that PA pressure drop is not absolute because sometimes there's a delayed response, and sometimes that's not necessarily the metric we're going for, but it is nice to see when it does occur. Well, and that's it. Thank you very much. I appreciate it.
All right. So now we have a lot of discussion about the different techniques. We've gotten a flurry of questions about technical details. Jay Matthews, you showed an example of using the flash system. Let's address a couple of important things. Number one, what's your goal, as you pointed out in this case, of your thrombectomy, and how do you set limits on thrombus removal versus blood loss?
Yeah. So fortunately, with the Flash 3.0 system, they've been able to significantly reduce the amount of blood loss. And my average EBL for these cases is typically between a 50 to 100 cc's, which is really, I think, fairly negligible. Now, my goal is to reduce the major obstructive thrombus. I'm not trying to achieve perfection because perfection has never been shown to really improve patient outcomes. In fact, I would argue it makes things worse. So we look to see that distal arborization, look at the levo phase as well too, to see how long does it take for that blood to return. And those are the types of things that I like to see when we're trying to do these procedures. First, do no harm. And it also improves your efficiency because you can really do your thrombectomy time in between 7 to 10 minutes and not really belabor the point.
So Jay Geary, what about with other devices? I mean, are they all similar in the approach, or how do you decide in terms of choosing one of the devices for the types of clot that you see on the CT angio?
There are technical differences between the devices. And I think Jay Matthews nicely covered that one of the key differences is just size, that we are going in with different size catheters now, whether they're moderate bore or large bore. With that size, it could also impact how effective you might be at taking out larger, more bulkier clot naturally with the larger device versus fishing down a little bit lower with devices that may be tailored for vessels that are more medium sized.
And Sanjay, what about in terms of, Jay talked about, looking for the arborization and the perfusion. Is your technique to do a PA-gram first, or do you just rely on the CT? And how do you know when you're done? Is it as a pulmonary angiogram? Is it hemodynamics? What are you looking to achieve there?
Yeah, if the creatinine is normal, I still do a upfront PA-gram. I know other people have moved away from that and really just gone after the thrombus and looked at it afterwards. I still think it's helpful because the clot can sort of shift and move and depends on how much time has elapsed from the CAT scan. In terms of when you're done, it's still an evolving question. Certainly, we look for some sort of hemodynamic improvement, whether that's heart rate, blood pressure, PA pressure coming down potentially, but those things are not absolute. And taking the anatomic factors, as well as how much clot you've removed, and plus the vital signs can help give you a picture of when you're done, but it's still an evolving target.
So, Greg, you've been involved in PE therapies for a long time as a non-interventionalist. Do you have input as the clinician who's been caring for these patients for so many years into the technique? And how do you guys decide that? Is it local expertise? Is it clot morphology? Is there some secret sauce that you guys use to figure out what device to use?
It's a great question. I think that it's a conversation always with the interventional team because we want to make sure that first they are comfortable with this, the technology. For me, the location of the thrombus matters. If there's a lot of distal thrombus, I think that sometimes a lytic-based approach will help to sort of get what is out of reach for some of these thrombectomy catheters. I think, really I've been reaching more and more for the patients that are hemodynamically unstable for mechanical thrombectomy. I think it provides a quick reperfusion and can be mobilized. And so that's oftentimes what the conversation will go to in a PE response team call. But for patients that have a lot of respiratory symptoms, we're going to talk more about the guidelines in a second, but patients that have that respiratory modifier where that's such a prominent feature and thrombus is more distal, my experience has been that a lytic-based approach can be beneficial for those patients in their recovery.
Okay, well, so with that preamble, Greg, so let's get on with it and let's get to the guidelines and how we translate this evidence into clinical practice. I'll let you take the lead there.
Excellent. All right, so we'll dive right into the guidelines. I'm thrilled to be joining all of you at home and the faculty. Here are my disclosures. And we're in a really fortunate time in pulmonary embolism with the latest set of guidelines from the AHA-ACC and multi-specialty group. If we look at the landscape before those guidelines came out, we had challenges for sure in pulmonary embolism care because of heterogeneity in the recommendations. For risk stratification, that's an explosive area of research in pulmonary embolism. We can see that in general, guidelines seem to recommend that we should be assessing patients for risk, although some of the guidelines don't have clear recommendations for that. The majority of guidelines recognize that there are some patients that are low risk and some patients that are high risk. But in the middle, there's quite a bit of heterogeneity in this figure, as sort of marked by the yellow areas. Certainly, most, if not at least half of the guidelines recommend some kind of multidisciplinary approach to assessing patients. It's not just all about management, it's also about identifying patients with risk. I can move us forward here. Looking at the risk stratification algorithm that came out of the ESC guidelines in 2019, this has really been the backbone for trial design and for clinical care. Really hinged on, first of all, is the patient hemodynamically stable? If they're not, then it's a high-risk pulmonary embolism, and those patients typically require more advanced measures. And we talked a little bit about how we think about different interventions for those patients. If the patient is hemodynamically stable, then we use either a bedside severity index like PESI, you can use BOVA, Hestia, there are a lot of different scores, but the ESC guidelines really were focused on PESI score or the simplified PESI score. And then looking at CT and biomarkers or echocardiography to assess right ventricular function, strain, or myonecrosis. If the patient is low risk on a bedside score or even the clinician's clinical gestalt, and they have normal RV and normal troponins, they're low risk and they're going to do very well with anticoagulation alone. Frequently in Europe, these are patients that will go home on anticoagulation. For patients that have high-risk clinical features, maybe an abnormal RV or an elevated troponin, but they won't have both, those are intermediate low risk. And again, a population that does traditionally very well with anticoagulation. The area of interest for PE response teams and for clinical trials have been the intermediate high-risk PE patients, those with abnormal right ventricular size or function on imaging and an elevated troponin. And the guidelines as of the ESC in 2019 were to watch those patients very closely and consider reperfusion if there's deterioration or if for some reason they weren't responding to anticoagulation. 2026 really marked a transition point for risk stratification and the identification of different phenotypic expressions of pulmonary embolism. I would say that this was a long time coming, and I would also say that the ESC guidelines in 2019 seem to reflect already a desire from the clinician and the researcher to understand risk in a more graded fashion. We transitioned from low risk, submassive, and massive to low risk, intermediate, and high, and then to low risk, intermediate, low, intermediate, high, and high. And here we have one more major category to help us understand a little bit more, probably precisely risk in patients. So we have Class A, which are subclinical, incidental, and asymptomatic PE patients. These are typically PEs found on scanning CTs done for some other reason, maybe for cancer staging, or maybe a CT scan done for abdominal pain. Category B are symptomatic but with a low clinical severity score. These can be subcategorized into subsegmental and non-subsegmental. A and B typically do very well on anticoagulation, and we'll talk about how the guidelines really recommend that these patients be considered for home PE therapy. Class C or clinical category group C have elevated clinical severity. C1, normal RV, normal biomarkers, but elevated markers for severity on a bedside scoring system. C2 having an abnormal RV or elevated biomarker, but not both. C3 having both abnormal RV and elevated biomarkers. And then a new change to the guidelines is the recognition that pulmonary embolism patients don't always just come in with cardiac symptoms. They can have very prominent pulmonary features to their phenotype, to their presentation, and the R respiratory modifier gives us a chance to reflect that. D is a new clinical category completely. These patients were unfortunately traditionally missed in all of the other classification schemata. These are patients that have incipient cardiopulmonary failure. D1 would have transient hypotension but then have recovered, but we all can recognize that that's not a good thing for our PE patients. And then D2 are patients with normotensive shock. And that we now give guidance in the recommendations for the use of lactate to detect these patients and other metrics. And you can also have a respiratory modifier for these patients. And then category E are the patients that we consider to be high risk. They have cardiopulmonary failure, either recurrent or persistent hypotension with cardiogenic shock, or refractory cardiogenic shock or cardiac arrest. E2 being a category that we would think of as the right patient for mechanical circulatory support, such as ECMO. And again, you can introduce the R modifier for those patients. So a little bit more granular. I don't think they're much more complicated. I think they just enable us to communicate better what kind of severity of patient we're either seeing, planning for an intervention, or transferring to a more monitored setting. The nice thing about the AHA-ACC guidelines is they include this scoring system or this categorization into the recommendations for therapy. And you can see that for A and B, we're really looking at DOACs and home therapy. For C and up, we're thinking about low molecular weight heparin, which is a very important recommendation. It's reflected in all of the major ongoing trials that we really want good quality anticoagulation. We do not want subtherapeutic PTTs with unfractionated heparin. The only caveat there would be E2, where we're thinking about significant mechanical circulatory support interventions where we might think about using unfractionated heparin. And you can see here, class 1 recommendation for low molecular weight heparin in C1 to E1. Looking at recommendations for anticoagulation, this predates the AHA-ACC guidelines, but really does have some good consistent messaging from the different writing committees. If you think the patient has pulmonary embolism and you have a reasonable pretest probability, go ahead and treat them while you're awaiting the definitive CT scan. If you diagnose objectively the PE, anticoagulation has to be the cornerstone of therapy unless there's a contraindication. And up until the AHA-ACC guidelines of 2026, there was a lot of heterogeneity on what to do with low molecular weight heparin, but I think the guidelines really help to clear that up. Looking at advanced therapies, we can see that the guidelines up until the latest ones from the AHA and ACC had a strong, consistent recommendation for systemic fibrinolysis based on limited data, but a strong recommendation nonetheless. Heterogeneity when it comes to reduced dose fibrinolytic therapy, certainly not recommending fibrinolytic therapy for stable patients. Looking here at the AHA-ACC guidelines, a step back, but I think based on the evidence that we have, really taking that previously level 1 recommendation for systemic fibrinolysis and walking it back a bit to a 2A recommendation. I think that's appropriate based on the limited data. There will be more data forthcoming on systemic fibrinolysis, and that's important. But I think we have to recognize that small RCTs shouldn't be carrying probably a level 1 recommendation. Looking at catheter-based fibrinolysis and mechanical thrombectomy, now elevated to a 2A recommendation for patients, especially those with E1, and 2B for less than that. I think more data, including HiPytho, Peerless 2, PE Tract, and many, many others will help to recommend these therapies with a little bit more precision. Very important recognition in the 2026 AHA-ACC guidelines is the pivotal role that PE response teams play for risk stratification, for access to advanced therapies, for essentially weaving a thread throughout the continuum of care and making sure that where there's evidence, patients received evidence-based care. Where there's lack of evidence, there's a consensus approach. You can see here in the diagram that it's really for C, D, and E that PE response teams are the key point here. The 2026 Acute PE Guideline at a Glance document by Dave Dzezinski provides some very nice recommendations, some overviews on how to think about things. I think the main take-home points are the importance of low molecular weight heparin, the pivotal role that PE response teams play, and the elevation of the role for catheter-based therapies. I think these are very nice areas where there's a bit more guidance now thanks to these guidelines. For long-term management, once we get patients through the acute PE, we want to make sure they don't have recurrences, and there's good guidance from both the ISTH and ESC about how to categorize patients and think about whether they should get extended secondary prevention. There's a lot of heterogeneity still in recommendations, but there have been some important trials since these documents that I think will help us to understand who needs to get extended thromboprophylaxis and how to do that with a DOAC, for example, whether it's low intensity or not. Follow-up care remains quite a question and an area of heterogeneity, especially for looking for complications like post-PE syndrome and CTEPH. And lifestyle modification, there just aren't a lot of randomized controlled trials to give us level 1 evidence on what to do with these patients. The ESC guidelines make some recommendations, and so do the latest AHA-ACC guidelines. Really, the best we have right now is early ambulation, medication adherence, heart-healthy lifestyle, and monitoring for complications of PE. And with that, I thank you for your attention.
Okay, Greg, that is an incredible tour de force of the guidelines. I know you had an incredible role in the guidelines, but one thing that seems to keep coming up in our questions is that the guidelines are really important and they've been updated, but the decision to intervene on patients is frequently still a clinical call and a judgment call. And I think that stepping through the different strata of the new guidelines through with the A through E categorization helps in that decision making. Tell me how you guys are implementing it in your practice at the Brigham.
Yeah, so we actually have a quick phrase or a smart phrase on Epic that includes the AHA-ACC schema. And we designate where the patients fall, and then actually we follow the AHA-ACC diagram that links the schema to the recommendations fairly closely. We are morphing our PE response to incorporate the AHA-ACC guidelines more carefully, including recommendations about low molecular weight heparin and when to consider interventional therapies. So for us, I think there's been a good embrace of the AHA-ACC guidelines. Jay and Mark Krieger and Jeff Barnes spent a lot of time making sure that these guidelines were going to be something that the clinician could use, and we're finding that that's absolutely true. Finding it very easy to work these guidelines into our local protocols for PE.
So, what about the fact that a lot of the interventional data are going to happen right after the guidelines were put together? And Jay Geary, I know as an interventionalist, you're incorporating this in real time. So what do you recommend for sites where they're trying to incorporate these newer data with the trials that Sanja mentioned that are forthcoming? How are we going to put that into perspective, or should we wait for the next ESC guidelines, which I hear are coming not in the not too distant future?
The existing AHA guidelines, the wording was chosen with some care and nuance. Specifically, when you look at that D1 and D2 patient population, although it's a 2B indication in the guidelines right now, and that was prior to Hypito's publication, the phrase may be considered is already used. Whereas with C3 patients and C2 patients, the phrase uncertain is used. I think it's notable that the trials largely that are being performed are enriched populations that where probably many of the patients are going to fit into category D type classifications. That certainly seems to be the case with Hypito, although we wait for that clarification in future publications from that group. Thus, I do think that we expect these guidelines to change and in an efficient manner as soon as we have completed all the intermediate risk trials, which we expect to happen within about 2 years for them all to report out. But even what you know now has some nuance that I think does allow for permissiveness, particularly in the class D patients.
Perfect. So I know everybody in their trial groups is trying to map their patient population to the new guidelines. And if you come up with an algorithm that we can all use, we'd appreciate seeing it because all the data dictionaries are not lined up. Sanjam, low molecular weight heparin is an important recommendation, but we as interventionalists historically hate low molecular weight heparin because we can't reverse it and we can't measure it. How do we reconcile that for those of us that are considering interventions? And Greg did point out that for the highest risk strata, maybe unfractionated heparin is still okay. What are we doing at Columbia, and how should people out there change their algorithms in their emergency rooms?
Yeah, we've been moving towards it, albeit admittedly a little bit slowly, but we have been moving towards it. It doesn't seem like it has an impact on bleeding hazard post-intervention or peri-intervention. And we do give bolus heparin on top when a patient's on low molecular weight heparin to check ACTs because the ACTs are almost never therapeutic by that metric. As you mentioned, it's difficult to measure, but because it is a venous access, it does appear to be fairly safe, and we've been moving in that direction regardless of whether a patient needs intervention. It looks like registry data is moving in that direction, supporting that as well.
Jay Matthews, are you guys practicing similarly, or are you still on fractionated heparin? What are you guys doing?
Yeah, it's a mix. It's been hard to get folks in the community to switch over to using low molecular heparin, even though it's more effective, more bioavailable. Again, a lot of reluctance amongst the interventionalists to use it because you can't reverse for a theoretical bleeding risk. The reality is the bleeding risk is pretty negligible. So I think that you can go ahead and dose a low molecular heparin and then give heparin in the cath lab as per usual. So it really shouldn't limit you to be able to do what you need to do for your interventions.
And then we talked a little bit about follow-up care, and we'll get to that a little bit more. But Greg, what are the biggest unmet needs in the studies to understand follow-up, and when are we going to get more clarity on the follow-up schema as well as on the sort of the way to identify CTEPH, CTED, and some yet unspecified sort of category of dyspnea that seems to occur in a large number of patients after PE?
Yeah, you hit it right on the head, Sahil. The biggest issue I think that we're faced with right now is the follow-up focused on identifying which patients are going to have chronic sequelae of pulmonary embolism. We have a little bit of a sense of some of the predictors of post-PE syndrome. We've got some idea of things that predispose patients to developing CTEPH, but they're neither very specific nor very accurate. And because of that, oftentimes we end up getting surprised with patients who should be doing great but have evidence of post-thrombotic syndrome, post-PE syndrome. So that's one of the challenges. We're really in the dark ages when it comes to lifestyle modifications for pulmonary embolism. I think we have some basic understandings that, if the patient has a high BMI, we want to get them to a lean BMI. We can follow the Life Simple 8, for sort of lifestyle changes. But a big question is, can we impact post-PE syndrome by some sort of exercise training? And is there an exercise training or a cardiac rehab platform for helping these patients? I think that we will get good information from PE Tract. We probably also will get some information from the long-term outcomes from HI-PEITHO that will give us clues onto how to focus our efforts to prevent these long-term sequelae. But we have to, I think, probably put as much effort as we're putting into the acute care into the chronic care if we want to unpack and understand how we get patients to recover and stay recovered after PE.
All right, we'll get to some more of those conversations. Now, I'm going to bring Jay Geary in. Jay's going to talk to us about more technical details with mechanical thrombectomy, and then we can geek out on some of the technical details and some of the hemodynamics. So, Jay, take it away.
Thanks so much, Sahil. So we're going to go through a case. It's being performed with the Stryker and Ari FlowTriever system of large bore mechanical thrombectomy. This is a 64-year-old man who did present to a hospital that was not ours and had shortness of breath for about a week. He did have this remote history of intracranial hemorrhage. And obviously, he did receive a CT scan that did show extensive bilateral pulmonary emboli, as well as some residual DVT in the right leg. His initial vitals at the outside hospital actually were pretty solid. You can see his blood pressure was normal and he was satting okay on room air, but he did have some tachycardia, heart rate of 110. His lactate, importantly, was also normal. And this is what happens in our hospital often is that, that an outside referring may just send me a text video of what's happening in terms of his PE scan so I understand what's happening anatomically. And this is the video I received on this case, which showed bilateral main PA thrombus that extended down into interlobar arteries bilaterally. So that's very useful to kind of put that together in my mind with what's happening. This patient did qualify, as Greg told us, instructed us on earlier. He's an AHA-ACC class C3 patient here, which is what we found. That is that he has positive biomarkers, that troponin and some RV dysfunction, but then was hemodynamically stable. The outside hospital also performed an echocardiogram prior to transfer, and we had a surprise. A large clot in transit was bouncing around in the RA. Now, this ups the ante for us, and we organized for emergent transfer. This hospital did not have a PE team nor cardiac surgical backup at its hospital. Patient was transferred to us, and luckily he made it here, but then immediately upon getting here, basically to our ICU, which is next to our cath lab, we were all seeing him at once, waiting his arrival, given what we saw there. He experienced brief syncope. Immediately, nurses and some house staff were at the bedside and administered very brief CPR. He actually didn't even get a dose of epinephrine, and he did recover very quickly, and he was alert and oriented ×3. He did get a repeat stat CT scan, actually, that showed that there's new saddle PE. So some of that clot moved, not surprisingly, but we still have some residual clot in transit. So a piece of it broke off and went north in the lungs, but this residual is still happening at the bedside. And of course, what we have to think about here is, what do we do about this? There were some stat labs drawn that actually came back a little bit later. Interestingly, his lactate remained normal, but his respiratory status, to Greg's point, was very destabilized on 100% non-rebreather now. So what's happening there in terms of where he stands? Now he's what I would call a class D1R. He basically experienced brief syncope, not truly an arrest, but he has a respiratory modifier with that 100% non-rebreather. So he's moved up the scale from a C3 to a D1R. But of course, he has that clot in transit, which, as we recognize the guideline, probably kicks you up another category. He's functionally a class E patient if you add that into the mix. So what are the questions of how we're going to manage this case? It's actually quite difficult. Are we going to use catheter-based surgery or surgical embolectomy? Are we going to treat the clot in transit if we go endovascular versus a PE versus both? And do we need mechanical circulatory support? So we went ahead and tackled this by deciding on an endovascular strategy here, where we used the FlowTriever, and you can see a stiff wire going up on the left side to deliver the 24 French, the entry sheath. And then we go ahead and we leave the FlowTriever itself right at the junction of the RA IVC, and initially take a pull, which creates such negative traction on it that you can see that what's going to happen here on the scan, and I apologize that echo doesn't seem to be playing in real time, but you would be seeing that clot disappearing into the FlowTriever. And oftentimes that happens even basically without entering the RA, but sometimes you have to pass it into the RA with TQ aspiration. Next, we go ahead and introduce a pigtail and take pictures of the lungs, as was mentioned earlier. And we've got pigtail catheter go up there, which is based over wire, which can sometimes go through an angled pig or sometimes needs more directionality, a JR catheter. We like to go ahead and take an angiogram. We can take a central angiogram from the main PA or individual ones from the right PA and left PA. In this case, we took an individual one in the right PA to clarify clot burden. And then we're able to then switch that out for an Amplatz super stiff wire with a 1 centimeter tip, which we have deposited in a segmental artery. That allows for deployment of the 24 French FlowTriever system, which then aspiration is performed, as you see here where it's deposited. You end up seeing that you are going to take it to the edge of a dilator that has a very short tip and remove that dilator, usually in the distal main PA or the mid interlobar artery, or sometimes the proximal truncus basalis, depending on what your PA gram looks like. If you want to, you could put a mother-daughter technique of smaller 16 or 20 French catheters through this to go slightly deeper. In this case, we did use a 16 French catheter to get slightly deeper. You see that in the bottom third frame. And a lot of thrombus is removed. I apologize that those clips, I believe, are supposed to play, but are having some difficulty. But regardless, you see that we then go into the left side. We do have to, unlike what Jay Matthews mentioned, we're not going to flip this catheter over into the left side. We're going to redeposit a separate catheter with the stiff wire there, and then take the whole FlowTriever out, and then either use a 24 French or a curved 20 French device for the left side, depending on how deep we want to go. Usually the curved 20 French, we're going to go a little deeper. And you see here that we're going to then aspirate again on that side. And that's basically how the case goes. Here we got a lot of clot out. Interestingly, he went from a non-rebreather down to 2 liters nasal cannula. I mentioned the MCS question. In cases like this, we do have MCS in the room, and we often place a 4 French arterial left femoral arterial sheath, so we can quickly go on to VA ECMO if necessary. But more often than not, we get away without using it. So although we have the availability for it, and we occasionally have to crash on, it can be done very quickly if we have the access. More often than not, we don't need it, and we did not need that in this case. And as you can see, it was transitioned and discharged. Thank you.
Okay, great, Jay. That's a great case, and really gets to a lot of the technical issues. So let's go through the whole thing from the beginning to the end. Either for medium or large bore devices, access is critical. So let's just go with the interventional guys for a second. Pre-close or no pre-close, micropuncture or no micropuncture, and what's your favorite tip and trick for dilating up to get your big sheets in? Sanjam.
So we go no pre-close, micropuncture. Yes, if fellow inexperienced, but I think ultrasound is more key than micropuncture, no micropuncture, because really want to make sure that you have a good stick on the femoral head. And then what was your last question? Tips and tricks to get up. Um,
Yeah, and to dilate the tract.
yeah, I mean, Nick, spread and use your dilators.
Jay Matthews.
Yeah, I mean, 100% ultrasound. I pre-close now quite a bit because the nurses sometimes pull the suture, the figure of eight too early, and then they bleed all over the place. So that pre-close prevents that. Uh, the element sheath is super hydrophilic, so I really don't need to dilate up. So kind of tracks really nicely. And micropuncture.
Jay Geary, what do you
I
think?
use the micropuncture sheath.
Yeah.
Yeah. For flow retriever with the entry sheet, I use single pre-close, importantly, and then not double pre-close. It's a venous stick, but I think the single pre-close very helpful. Always use ultrasound. I don't feel as strongly about micropuncture, except for when we're performing catheter-directed lysis, different procedure, where I'm adamant that we use micropuncture because lytics are being administered. And then finally, I do use an intermediate dilator, usually with an intermediate sheet, before putting the larger sheet in. So something in the 12 to 14 French range, followed by the big sheet.
Yeah. So in the new catheters, there's a whole bunch of new catheters out there. Many of them are large bore. What's your favorite sheath, Jay Geary, for your big catheters?
I do like the Gore dry seal of whatever size is necessary is the typical sheath that I'll use for when it's not dedicated. I do think that Inari, Stryker Inari has done a good job of creating their own sheath that works well with their device, though. So I prefer that for flow retriever cases.
Yeah, but I think it's important to point out that a lot of the devices use dry seal as a workaround. I mean, when I started doing PE interventions with large bore devices, we didn't have great large bore sheets. And that was one of the biggest challenges. So I think it's a important enabling technology. Okay, right heart cath. What data do you acquire, and when do you repeat the right heart cath? Um, Greg Piazza, you're as a cardiologist, you love hemodynamics. What data do you want to see pre-post?
I, I don't often ask the interventionalists to do this during the procedures, but if they do it, I love seeing, the PA pressures. I think that you want to have a sense that the PA pressures are coming down. It's oftentimes, especially with thrombectomy, not a dramatic decrease, but it's usually enough to tell you that the situation's well under control. Those are the things. I don't spend a lot of time looking at cardiac output for these patients. Oftentimes, unless they're coming in a D1, D2, or an E, if they fall into that category, then I would like to see measures of output. But those are the main things.
Okay, so Sanjam, I think we think about it maybe a little differently. I think how many times do we see a patient who's in normotensive shock with cardiac indices less than 2 in these patients, and what are you doing differently at Columbia?
Yeah, the data would suggest, in our experience is similar, is that about 40% of the patients that come to the lab are actually in that normotensive shock state. So despite lactate is not the only arbiter of shock, and I think it really is helpful to understand where the patient is on the Frank-Starling curve, and that can have impacts on which device you use, as well as how you potentially think about and treat the patient afterwards. So we're getting a full right heart cath numbers without the wedge, so RA, RVPA, plus the cardiac output and index by FIC, and then using that as a tool to understand where the patient is, because your PA pressure may go up or down depending on where you are in terms of your cardiac output or index. So somebody has a very low cardiac output, their PA pressure may actually go up, and that's a good thing, versus somebody whose cardiac output is more preserved. So I think it is very helpful. We will generally post, we'll do a PA pressure and a PA SAT.
Jay Matthews, any other thoughts there?
Yeah, I mean, notice I always get that second axis. So through the pigtail catheter, I can get the PA pressure real time and also do a quick FIC as well too. That's it. I don't do a full right heart cath every single time, but that information I think is really important to decide which device you want to use. Some of these sicker patients, you're better off just going small bore, and catheterectomy thrombolysis can be appropriate for some of these patients as well. So I think it just takes seconds to really do it. I don't necessarily get it post. I'll get a PA pressure, PA sat, but I'm not going to do a full right heart cath afterwards.
And Jay Gear, again, to think about this a little bit, is there a metric that you see in the right heart cath, if you get it, that tells you maybe I should go on MCS first? And what is it, and how do you guys think about that?
The single most important metric is derived, in my opinion, by obtaining the pre-PA sat, which both Sanjam and Jay alluded to. And what you calculate there is the stroke volume index. So go a step beyond the cardiac index and take into account the heart rate compensation that the PE patients are experiencing. That when stroke volume indexes are very diminished and they can get to exceedingly low levels in PE patients, then you want to be thinking about, at least do I have access to be able to crash on to MCS very quickly if I need it. And the specific thing I'm thinking, I start to think about it when the stroke volume index is less than 20, and I'm always putting in that access when the stroke volume index is less than 15.
Okay, I mean, and these are metrics that can be readily calculated very quickly at the bedside. It's just arithmetic. It's not integral calculus or anything more complicated. So it is important, I think, that we teach people how to do this because I think it's an important measure of risk that it's not often talked about. I don't know where it really falls in the guideline discussions, but every experienced team that I'm aware of thinks about these things before they start intervening. Are there any red lines? Is there any number below which you say, I think we shouldn't do anything catheter based. We should just get these people on support and then think about what to do? Jay, what do you think? Jay Geary.
Yeah, so I would say that the big thing is we will use catheters after they're on support in some cases. I think that's the key. The support facilitates the catheter-based therapies really well, and either one, mechanical thrombectomy or catheter-directed lysis, can be really nicely employed after support. So, like I mentioned, if somebody is on, and that specific group is categorized in our guidelines as E2 patients. So those patients who are having escalating pressures or have experienced a cardiac arrest but is resuscitated, we are recommending those guidelines with a two-way recommendation if you have the ability to get them on MCS as a first step. Then you can take a breath, sometimes a breath for several hours even, because they're supported. Get your team together and then go ahead and do a catheter-based therapy to minimize the time they're on support, because that's going to what enables you to get them off sooner.
And Greg, in your setting, yeah, go ahead.
I said I'll argue that the one caveat is those patients who come in with a mixed picture where they're acute PE, but also maybe decompensated CTEPH and their PA pressures are up in the 90s and 100s and their PA sats are very low. Those are patients may not be appropriate for catheter therapy, and you really want to think about support plus an alternative strategy.
Yeah, so Greg, getting to that group exactly, when do you incorporate the shock team of your institution, and how do you incorporate surgical therapy for those advanced risk patients?
Yeah, it's a great question, Sahil. I think that the shock team is weaved into our PE response, especially for and as we reimagine things now in the wake of the 2026 AHA/ACC guidelines, we really are looking at that E category patient for consideration of the shock team. Maybe not every E1 because those patients oftentimes are doing fine on one or two pressors and then coming off if they're intervened upon quickly, but certainly for the E2 patients. And then I think really, we look towards their expertise on how best to support the patient as they, move through and hopefully stabilize.
So, again, at Columbia, we can get ECMO easier than a ham sandwich, but in most places in the real world, that's not feasible. So how do we help our teams out there that are building their PERT teams in community-based settings come up with an algorithm for management of care? What's their approach and where should they go? Jay Matthews, you work in a community-based center that has a lot of capability, but I'm sure you have referring sites. that have fewer capabilities than yours? How do you guys interface with those sites, and what do you recommend to them over the phone when they call you with a sick patient?
Yeah, so this has been an evolving thing over the last decade, and initially started off with simply text messages and making sure that there was some algorithms provided for these ERs and outside facilities to know how to escalate care when appropriate. We also do now have communication capabilities through some app-based tools. There's a number of them out there that can be quite useful, so that you can easily communicate as part of the PERT team. But I think the key is having an algorithm and having a way to escalate, knowing who to call so that there's no delay in care. People love algorithms because they know how to follow them, and hospitals like them as well too. And ultimately, with the community programs, they want to have a disposition so that they can find a way to refer out very easily and clearly as well.
Okay, so let's talk about the future. Everybody's talking about AI in every domain. Where are we interfacing with AI here? And where do you guys see as the future? Um, let's start with the role of diagnosis. How many of you are using AI based CT algorithms to help activate your PERT teams? Anybody want to talk about that?
Yeah, so we're not
Takers?
at the point where we're using AI, clinically for the identification of patients being diagnosed with PE. Although that certainly that functionality exists. It's been used for enrollment in clinical trials to identify patients quickly who need to be evaluated and randomized. And I think in that way it's very helpful. But I think we're using it more for risk stratification right now.
Yeah, it sounds
That's
like Jay
part about the
Matthews
AI
would agree.
tools.
Go ahead.
The best part about the AI tools right now is just that they can collate the information that's necessary in an easy to use format for you in an app that's user friendly. That information all exists. So I don't think they're actually exhibiting intelligence yet that influences care. They're more of a secretarial approach of collating the information, which is useful. You have a scan and you have a potentially categorization, you have vitals, you have all these things. But the next step is trying to help us to give recommendations on who's going to benefit or not based on things like clot chronicity and likelihood to respond to different therapies. We're not there yet, but I'm very hopeful that that's where we'll be moving.
Yeah, but I think that one of the biggest vexing things is when we see clot, we often don't know the chronicity, and we get in there with a large bore device, and we're having a hard time getting anything out, and then we bail to a pharmacotherapy or pharmacomechanical approach, and it would be great to know ahead of time which patients will be best served by which therapy. What about the different therapies? We have value analysis committees in our center. I'm sure all of you have similar sorts of groups, tribunals, as I like to call them. How do we innovate technologies if we can't get them on the shelf? And how do we try things out if we can't get our hands on them? Any suggestions? Yeah, I will just go around the horn. Sandra, what do you suggest?
Yeah, it is a difficult question because I think once the number of technology starts to proliferate, and you have devices that are in the same segment, you have to make some decisions. I think it's important that you be at least familiar with one large bore technology, one medium bore technology, and one lytic technology. I think understanding at least those three broad categories, as Jay laid them out, is very important. But as you try them out, I think it has been successful to do one-off cases, bill-only cases, trial cases to at least get familiar. But I think expecting to have every single device on the shelf is obviously unrealistic.
Jay Matthews, you've been involved in a lot of the early trials. What are the features you're looking for in a next gen technology that you think will be a game changer?
Yeah, I mean, as we talk about how do we bring new technologies to the shelf, I mean, it has to ultimately be better than what we've been using before. So, uh, being able to address clot of varying morphologies, being able to navigate through the the pulmonary vasculature atraumatically and very easily, making the procedure efficient, so reducing the overall procedure time. These are all features that I look for in these next generation systems. So I think that there's some interesting stuff out there too. But I think the intelligent, I think there's a number of companies looking at computer assisted or computer aided algorithms to intelligently change the modality of how they address thrombus. Also giving you real time feedback on hemodynamics as well too, pressure volume loops, all sorts of things, which can be really exciting as we try to address these patients so that we can predict how are they doing. So you know when you're done, those types of things I think are exciting possibilities.
All right, we have about 60 seconds left. Any last burning comments you want to throw out there? Um, Jay Geary and Greg Piazza, I'll give you guys the last word.
This is the most exciting area of interventional medicine from an evidence development standpoint. We're in the midst of the publication of several mega trials, up to 7, that are all happening in a in very rapid fashion. You're going to see probably 7 mega trials published over a 3-year period in those Class C2 to E1 patients. I can't say enough that this is extremely exciting that that's happening, and you want to keep up abreast with it and be evolving your practices in real time here.
And Greg?
I would say I very much agree with Jay. This is probably the most exciting era of pulmonary embolism research and clinical care. I would say we are also really excited for the potential impact of AI on risk stratification and identification of patients that will benefit from interventional therapies. I think that's going to partner really nicely with the mega trials that are going to come out. I think we'll learn, which devices work well in which area, and then we will have a sense of which patients to select for those devices. And AI can just help us take into account so many different variables that you couldn't possibly ask a frontline clinician to record and recognize and calculate out a score. But we'll be automating that, and I think it's going to be a really helpful time. I think that plus P response teams really end up providing the clinician on the front line with everything they need.
Well, thank you guys. And again, I want to thank my panel for an outstanding presentations and discussion. And on that note, we're going to draw this session to a close. This is a really fast moving and exciting field. I encourage everybody to get involved. And we're now going to move our focus to the next session. Don't go anywhere. And thanks for being here.